When we think about medical breakthroughs, we often picture new drugs or surgical techniques. But what if the real revolution is in how we see the body? Imaging has always been at the core of diagnosis, but today's technology is giving us living, breathing maps of the lungs in action. I'm Dr. J. Rutland, and today I'm joined by my good friend, pulmonary critical care physician Chase Hall, also an MD, who's an Associate Director of Interstitial Lung Disease and the Rare Lung Disease Clinic at KU Medicine, where I trained. On this episode of the Health Exchange, we are diving into new imaging technology and how it is taking lung diagnostics to a whole new level. We're partnering with Polarean, an innovative imaging company, and focusing on their groundbreaking imaging technology, Xenon MRI, that allows clinicians to visualize not just the structure of the lungs, but also the lungs' function. Let's get into it. You know, when I think about our relationship, I've actually never asked you, what brought you into pulmonology in the first place?
That's a good question. It was by accident. So I really wanted to be an ICU doctor. I liked critical care. And whenever I was a med student, I knew that there are a few paths to become a critical care doctor. One was through internal medicine, one's through surgery, anesthesia. And I always felt like internal medicine doctors were kind of the prototypical doctor that I imagined myself to be. So I ended up going into pulmonary critical care through that pathway. So initially, it was actually the ICU that kind of led me to pulmonary.
What was it about the ICU? Was it the action of doing things to people? Was it the conversations with family in intense situations? What was it?
I think it was just how sick people are, right? I enjoyed how sick people were, and that when we make a change, when we do something, we see an immediate response right then and there. So whenever we're taking care of someone, we make an action, we see a response, so we immediately know if we're doing the right things in the ICU.
Is there a patient story that's associated with that thought then, that really helped define why you went into critical care? And then maybe we talk about how your career evolved.
Yeah, definitely. So I can remember a patient one time that was sent to the ICU from another hospital. They'd been managing that patient there. Actually kind of intertwines pulmonary and critical care here, but a patient had significant lung injury, ARDS, we call it. They were being treated with steroids and rituximab because they thought that it was some sort of autoimmune process. And they actually transferred over to the hospital that I was at, taking care of them in the ICU. And we treated them very aggressively with IVIG, steroids, and rituximab. Basically, the patient turned around. So someone that was on death's door with his family there, obviously extremely upset at everything that was going on, to now patient's doing wonderful, not even on oxygen, lungs look great. And it is those types of experiences and how quickly we turned the situation around that was very rewarding.
And so I guess what's happened in your career is it's kind of evolved from that critical care love to more of a pulmonary love. Describe how your career evolved over the course of time.
Yeah, and I think this is probably true of a lot of pulmonary physicians who are initially excited about the ICU, but you start to see that there's a lot of interesting physiology in the lungs, a lot of interesting pathology, a lot of autoimmune disease overlapping with lung disease. And so that's kind of where my path has changed now, right? I'm interested in how autoimmune disease affects the lungs, the treatments that we can give to improve those patients. So that's kind of how things have evolved there. And, interstitial lung disease and autoimmune disease, they kind of go hand in hand in a lot of cases.
So Chase, I know you know some of this story, but I trained where Chase now practices at KU Med in Kansas City. I wanted to be Chase. I wanted to be at KU Med. I wanted to be doing the ILD center with Dr. Hamblin at KU Med. I wanted that position, kind of. But I look at you and I'm just man, this guy's doing some fantastic things at KU, which was a growing program when I was leaving, right? And it's grown so much, and you've done such a great job being that interpreter for a lot of different people, for medical students, residents, fellows, and family members, which I think is important. What is your personal philosophy when it comes to caring for those people, caring for patients?
Yeah, whenever I'm taking care of a patient, I think the primary thing is I want to educate them on what's going on. I want to show them the CT scan. I want to show them their lung function test so they know what's happening inside their body, why it's happening, and then educate them on what the options are and let them help make the decisions on how we're going to move forward. I'm going to give them suggestions, my suggestions, but I want to make sure that they understand what's happening and feel comfortable with where we're going with things.
Yeah, so you're coming from a position of education where you want to create a foundation of education for the patients and their family members so they know what's going on and why you're doing what you're doing.
Yeah, for sure.
One of the things that's really exciting in our field in pulmonary and critical care is, and one of the reasons why I picked pulmonary critical care was really imaging. I wanted to be able to read all sorts of images from ultrasounds to x-rays to CTs, to MRs, and I wanted to be able to apply it to the patients that I was seeing on a daily basis. And again, I think we are in agreement on this. Our first love in our field was probably the intensive care unit because probably of imaging and the rapid changes you could see. What were some of the imaging techniques that you kind of grew to love in the intensive care unit?
Yeah, well, in the intensive care unit specifically, obviously kind of bread and butter things, chest x-rays, we get those all the time, make sure line placement's good, endotracheal tubes in the right place. But beyond that, especially as a lung doctor, integrating chest CT scan into our evaluation, the patterns of the imaging can tell us a lot about what's going on with the patient. And then I think evolving over our career has been ultrasound in the ICU, which has been an incredible tool to help us become better doctors in the ICU and manage things that we did in the past, but we're doing it safer now.
Yeah. And, you guys, when you look at ultrasound, the reason why we like it is because most of the time it's a handheld device where you have a probe in your hand, you're putting some gel on the patient's chest, and you're looking at their heart pump in real time. You're looking at what's called their pleural space. You're looking at the space around the lung, and you can see if there's fluid there. You can see if there's air there, if somebody's having a pneumothorax, so you need to put a tube in. And the reason why we love the ultrasound is because most of the time, if we got the ultrasound, it was probably going to lead to a procedure where we got to use our hands and put a needle in somebody. When you're looking at chest x-rays are all about densities, right? And you've got like 4 different densities you can see on a chest x-ray. You have metal density, which is your bone. You've got air density, which your lung is full of air. You've got soft tissue density. Most of your organs are soft tissue, so they're mostly water, and they're going to look really, really white on CT scan. And then you have the adipose density in individuals, which looks a little bit, I mean, it's white, but it's probably, I would say, a little bit more gray on x-rays. And the only reason x-rays actually work is because you have all these densities right next to one another. And we take advantage of that. And so I always tell students, and I don't know what you think about this, but I always tell students when they're learning x-ray, the only x-ray you ever have to memorize is a normal chest x-ray. Once you know what that looks like, every other x-ray that you look at from that point forward is always compared to that one.
Yeah,
And
for
you
sure.
can, yeah, right? And you can say loss of this or loss of that, or you can see this or that.
Yeah, you have to know what normal is to know what abnormal is.
Yeah, and that's the thing that I liked about imaging is just added things to our daily activity. Now, CT scans, which depending on what training program you go to, right? Sometimes your attending just thought you would pick it up, but it was never really formally taught to you. When you look at CT scans, people get all kinds of CTs, and specifically I'm talking about CT of the chest, right? And so they'll get CT PE protocol, or they get high resolution chest CT, or they'll get a CT looking at the aorta. How do we define these differences, or what's the evolution of
How do we pick which one?
Yeah.
Yeah. It's interesting because we throw around the word high resolution CT a lot. In most academic centers now, HRCT scan is kind of a standard CT scan, but historically, CT scans to try and avoid radiation, people would take thick slices, images of very thick slices of the lung, and then actually skip portions of the lung to take another slice. And so, this would cut down on the amount of radiation exposure. And then HRCT scans basically turn that into thinner slices, but they still may skip portions of the lung, which is okay if you need a few high resolution CT slices to see what the pattern is of the lung disease. But it's not good if you have a nodule or something there, right? You could easily skip over it. So really now we want to do thin slices, but we want volumetric imaging. So meaning you're imaging the whole lung. You're not missing any parts of the lung. So in fact, there is even overlapping slices. So you don't miss anything, right? This is important when we're talking about pulmonary nodules.
So a pulmonary nodule is really any abnormal soft tissue finding that's well circumscribed that's less than 3 centimeters in size, right? That's what we call a pulmonary nodule in the lung.
Now, when you're looking at pulmonary embolism and things like that, we may throw in some contrast, time it right so we can see what the arteries look like. Is there a clot or something in there to help define that? But when we're really talking about HRCT versus standard CT, the line's pretty blurry now, really.
For those of you watching, when you think about the lung, the basic unit of function of the lung is called the secondary pulmonary lobule. It's like this pentagon-shaped structure. There's a pulmonary artery in the center. There's a bronchiole in the center. The bronchiole is carrying air to the lung. The pulmonary artery is carrying blood to that capillary membrane. So when you take that big breath of air in, where that balloon fills up, you're going to have some gas exchange taking place. Carbon dioxide will come off, oxygen is going to go into the bloodstream and on the blood cell. And when you're looking at a CAT scan, essentially what you're looking at is a bunch of secondary pulmonary lobules all stacked on top of one another. And when he's talking about slices, he's talking about slices of the lung from top to bottom or bottom to top, however you want to look at, chew, 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 chew. And then they lay it on a screen and you can scroll through and see the different slices, and you're seeing secondary pulmonary lobules all throughout it. And if the secondary pulmonary lobule is accentuated, where if the fence that separates the pulmonary lobules is more white, we call it increased lung attenuation, right? Anything that's more white on CAT scan is increased lung attenuation. If it's more black, it's decreased lung attenuation. And that's essentially how we define the different images we're looking at or the different structures we're trying to see. So imaging really helps us detect the presence of disease.
Yeah, the presence and even what the pattern is can help determine what the diagnosis is.
Pattern meaning like where it's located or where the accentuation is? Or?
Exactly. So those areas of high attenuation you were talking about, are at the top part of the lungs,
Yeah.
at the bottom part of the lungs, at the inside parts or the outside parts. That's kind of helps determine potentially what's driving that disease process.
And imaging really helps us detect disease earlier, right?
Absolutely. Absolutely.
But we also have some instances where it can be tough to distinguish disease and what we're seeing. Are there any new imaging techniques that are up and coming that are going to allow us to be able to detect disease, I don't know, better or more functional? Because I look at imaging as like you're taking a quick picture. Is there anything that's allowing us to look at things like live in action?
When we talk about structural imaging, that's what I think about for CT scan, because you mentioned functional, and CT scan is really a structural test, right? We're looking, what are the secondary lobules looking like? Are there abnormalities structurally that we can see? Functional imaging is more looking at how it's working. A way to think about it would be Google Maps, right? Google Maps is the structure, the traffic overlay is the function. So that's a way to think about structural and functional imaging. As far as structural imaging, some new things coming down the pipeline that I think are exciting are photon counting CT scans, right? Photon counting CT scanners are going to allow us to see better definition, or do allow us to see better definition at lower radiation doses. So that's really important. We can tell contrast better, so we can differentiate structures better. A new functional test is actually Xenon MRI. This is essentially a test where you inhale xenon, an inert gas, and we look at where that gas goes throughout the lungs. And based off of that, we can tell how the lung is functioning in 3 dimension. We have other tests, spirometry, but it gives us a global value and it's not very sensitive. So this Xenon MRI can actually see where the gas is distributing, and it's very sensitive to small airway injury.
And here's what you guys got to understand, because this is what's really cool, is when you think about the lung, again, you have a bunch of pipes lead to a bunch of balloons all stacked on top of one another. So you are inhaling air, gas, whatever, from your environment. And that air has to travel down a road, like he said with the Google overlay and traffic patterns. That air is traveling down a road, and you want that air to go to a specific point in your body. You want it to cross the balloon membrane and get in your bloodstream and on that blood cell, because oxygen from the air is what gives us our energy to be able to be ourselves.
Exactly.
And what Xenon MRI is doing, and what Chase has just said, is you're watching the traffic pattern of the air that you're inhaling.
Exactly. So we call that first part ventilation, right? So where's the air going inside those air sacs? Is there small airway disease, mucus plugs that are blocking that flow of air? Once it gets to those air sacs, you mentioned crossing into the membrane and binding to blood cells. Xenon MRI can actually image that. So we can there's a small shift in the signal that we can image when the xenon's in the membrane or when it's bound to red blood cells. So we can actually see that happening in the body.
So you can see the difference of if it's stuck in the interstitial layer or if it's actually getting into the bloodstream and onto the red blood cell.
That is exactly right.
That's something really cool, because again, there really is nothing else that gives us that type of information. Everything else is estimated, right?
Exactly. I mean, we can do a DLCO, right? Measure how easy carbon monoxide transfers through that membrane and gets into our blood. But it's a global test, right? We don't know if there's an area, a specific area in the lung that's not functioning properly, we can't tell with the DLCO.
But with the Xenon MRI, you can tell which area of the lung the disease may be most prominent, and you can tell if that gas exchange is taking place. And you can even go so far as to say, hey, listen, if you take this portion of lung out, they're going to lose a majority of their ability to ventilate or their ability to oxygenate.
You can think of it, one, is just having that information. Where's the disease primarily taking place? Is there disease taking place, right? It's much more sensitive. But also, like you're getting to, guiding treatment decisions, right? Guiding procedures. And that is where three-dimensional information has always been helpful. One thing I think is important is we've talked a lot about CT scans already. Xenon MRI, I don't think is a replacement for the data we get from a CT scan. We still need that structural information. MRI is not quite there yet. We are doing some cool things with MRI, ultra short echo time, reducing the echo time of the MRI signal so we can actually see more tissue. Normally, you can't see the lung tissue on an MRI. There's just not enough there. We measure protons with MRI, and it's mostly air in the lungs. So a good alternative is CT scan for viewing the structure still. So we can actually merge those images, overlay those images with each other so we can see the structure from the CT scan and then the functional abnormalities from the MRI, which is extremely useful when you're looking at either destruction, interstitial lung disease, mucus plugs, any of those things. It's a great way to visualize both of those things in one place, kind of like a PET CT scan overlays the image.
So you're almost creating a differential diagnosis from the Xenon MRI based upon the results that you're seeing, I guess, like whether or not it's an obstructive problem or a destructive problem.
Yeah, exactly. I mean, sometimes these obstructive lung diseases are tough to see on CT scan. Maybe we see some mosaic attenuation, meaning some darker and lighter areas that suggest the small airways are involved. Some places, we always get expiratory images to look for air trapping, but you may not always be as clear. Those areas will light up, won't light up on Xenon MRI because there'll be ventilation defects.
Right.
The rest of the lung will show the xenon.
When I think about my patients with asthma, my patients with COPD, one of the things that they don't have is they don't have a good grasp of what it means to them other than their symptoms, right? They can't really explain it other than I don't feel good, or I'm just short of breath, or I'm wheezing.
Yes.
What I think imagery offers them is an ability to sort of show their disease to their doctor when they're not feeling good, so that some of these doctors have an idea for what's going on. Like it's an actual image. It represents them. It is them.
Right.
And Xenon MRI actually gives you that image of like, hey, this is your lung. This is what the inside of your body looks like and what it's doing.
Exactly.
And this is why it matters to you, right?
Right. Absolutely. I mean, if you're a patient with asthma and you're trying to explain to your doctor, I've got these symptoms, shortness of breath, wheezing, but your pulmonary function tests look normal, your spirometry is normal, and you get blown off, it's not because you're wrong. It's just not the right test to see the problem that's happening at that time, right? And so that's where Xenon MRI can be really helpful, right? If you can see these ventilation abnormalities that are objective and obvious and shows what the patient is feeling.
Yeah, a picture is worth 1,000 words. And so for me, I got a 12-year-old that has asthma, right? And so she will play for different soccer teams. And if I had an image that I could give her and say, you need to show your coach this. Hey, coach, this is what normal is. This is what my lung looks like.
Right.
And this is because of my asthma.
That's why it's tough for me to run sometimes.
Exactly.
Yeah.
So if I'm at that point, I need my inhaler because when I take my inhaler, it actually turns into this. Right. And you see how it's more close to normal.
Exactly.
And I think that that's cool for patients because it allows them to understand what's going on inside their body.
Yeah.
But I also think you can reach more people and inspire more people to go into what we do every day because of how simple it is and the imagery that you can see in a picture.
Right.
When I think about Xenon MRI, looking at those pictures is really easy. Like it's really easy to see.
Simple.
Yeah. Where the damage is taking place or what the damage is leading to. But how do you actually do the test? And like, we know with a CT scan, you're going to go into a room, you lay flat, you sit inside a donut, zip, and it's taking quick pictures of you. It's like a minute, right? What is it like for MRI? Xenon MRI?
I would say it's very similar, actually.
Yeah.
So instead of a CT scanner, it's an MRI scanner. So basically, the patient would go in, lay down on the bed of the scanner. They're going to have a coil, which is like a vest that's going to go around their chest, that's going to pick up the signal essentially. And then you're going to inhale the xenon gas, hold your breath for 10 to 15 seconds. They'll very quickly do the imaging, just like on a CT scanner, and then you're done. That's essentially out. You hold your breath, you breathe it out, and you're done.
It's really easy to do. It's really quick to do. And it's something that's going to hold value to the patient because they're going to have a picture. And I think from a compliance standpoint, if patients can see their illness,
Yes.
I think they're more compliant with their therapies. I don't know if you have that experience.
No, absolutely. If you can see a change that's happening, that's going to motivate you, right? Just like everything we do in life. If we do an action and we see a response to that action, we're going to be more committed to continuing. And I think that's true of patients, all sorts of diseases, asthma and others.
Now, you've had patients in your research and you had patients in your clinic, we've been talking about them, do Xenon MRIs. Is there a positive experience from a Xenon MRI where you're like a patient came in and showed me XYZ and really truly understood what was going on because I did this test?
I had this other patient who actually had COVID, and we were doing a research study looking at long COVID patients that have normal CT scan, normal PFTs, and looking, could Xenon MRI help answer what's causing their symptoms, because their symptoms were real, right? What we saw was that the RBC uptake was reduced. And so I had a patient, that came to me that was actually in this trial that had COVID, never actually saw the results of what happened. And we were talking in clinic, why am I so short of breath? And I was like, well, we imaged these people in with COVID, and she happened to be one of the participants. And so I showed her imaging, and she's like, it all makes sense now. I understand now that the vascular injury from COVID is what's leading to my symptoms. And she felt some peace from that.
Oh, wow. So the patient was able to, because of this test, the patient's able to understand what happened and they get
Exactly.
some type of resolution.
Nothing was answering that question before. There's nothing we could do about it per se. There wasn't a fix for the injury that we saw, but just having that answer was important to her.
In the monologue, we mentioned the word imaging, right? And we know as physicians that imaging is central to what we do on a daily basis. If I were just to ask you, why is imaging central to what we do on the daily basis, what would you say?
It plays a central role in detecting disease and diagnosing it. So, historically, we may have we still do this, listen to patients, hear what's going on to kind of get an idea, but we may have used tools like our stethoscope to listen for certain things, which still valuable, definitely don't compare to imaging answers that we get.
Yeah, 100 years ago, before we could do X-ray and CT and all that stuff, people used the stethoscope to get a glimpse as to what was going on inside, listening to the heart sound,
Right.
listening to the lung sound,
Yeah.
listening to the bowel sounds.
Tapping out the chest before sticking a needle in there.
Right. All of those things, right? But really what we were trying to see is what's going on inside.
Exactly.
And imaging was able to provide us with some of those answers. This is what's going on inside.
Yeah.
Right? With X-rays, which is like there's X-rays, there's CTs, there's MRIs, there's PET CTs, there's ultrasound. There's all of these different imaging techniques that we use. All of them help us, right?
Absolutely.
How would you explain the difference between a CT and an X-ray to a patient?
An X-ray is basically a simple two-dimensional image that's almost like your black and white TV back in the days, right? Whereas the CT scan is going to give us three-dimensional image. So we can scroll up and down through your lungs and see the whole thing. Extremely high definition. Think of it as like your new 4K TV. We can see what's going on in there actually. Otherwise, the X-ray is kind of a hazy picture of a general idea of what's going on in there.
Yeah, the X-ray is like this black and white piece of paper that you have on a countertop. And the CT almost like you said, three-dimensional, just widens that paper and lets you know, is it in the front or is it in the back or is it down low and up high? And it really provides you with that information. And ultrasound uses sound waves so you can sort of differentiate between different structures, like the heart and the fluid in the heart and fluid outside of the heart, or fluid in the lung, fluid outside of the lung,
Right.
fluid in the belly, fluid outside of the belly, right? And so it really provided us with what we needed objectively to be able to look inside a patient's body like Superman, right? And see what's going on and if there's something we need to do about it.
Yeah. I mean, if I were a patient and someone's tapping on my back to determine where the fluid is to stick the needle in, but they have an ultrasound sitting right there, I mean, you got to be kidding me.
Right. No, I mean, an ultrasound has almost made the stethoscope obsolete.
My experience is now, no matter how good of a you are at your physical exam, we're still going to order that echocardiogram to get the real answer, right?
Yeah. It doesn't matter what you do. We're going to use the image to sort of give us an appropriate differential diagnosis or diagnosis and tell us what we're going to do to help.
Right. And the patients want that, right?
Yeah. And when you look at imaging in our field, in pulmonary critical care, it's really allowed us to do our jobs better.
Oh, yeah.
Hey, I mean, specifically, I mean, I'm sure in your intensive care unit, which is what drew us both to the ICU, you got an ultrasound and you take it everywhere you go.
Yeah.
Right?
Making good doctors great.
That's exactly what it does, right? It makes good doctors great. Like I got a phone call yesterday. I get a phone call from a patient's son who says, my mom is sick. She's short of breath. She's in the hospital or at the urgent care. Should I send her to the hospital? I'm like, send her to the hospital. I drive up from San Diego, right? My daughter was playing soccer in the morning. And I go to the hospital and I get to the bedside and she's struggling to breathe. I immediately get the ultrasound, right? The echo probe, right? Of the heart to look at the heart pump in real time.
Yeah.
I look at the heart pump in real time. It's not squeezing as well. I know that her ejection fraction answers. Yeah, immediate. Not only that, but then I look at the lung on the right side, I see a bunch of fluid. I look at the lung on the left side, I see a bunch of fluid. And I use that ultrasound to stick a needle in and take out all the fluid. Took out 1,100 cc's on the right, 950 cc's on the left.
Exactly. An actionable item.
That's what imaging does.
Exactly.
Right?
Yeah, for sure. It's amazing. I mean,
unbelievable.
Indispensable.
100%. I mean, so much so that I bought a butterfly ultrasound. I have it at home. I have two.
Everyone has one now.
Right? Everybody has one, right? I hook it up to my phone and I can image my daughter. Yeah. I can image, my friends. And it's so funny because my neighbors will come over and they're like, hey man, my stomach hurts, or like I'm kind of short of breath. Can you use that ultrasound and put it on my skin? It's like hilarious to me. And I'm like, I could do it.
Yeah.
Right. Yeah, exactly. Yeah. In pulmonary medicine, what images do we use today? Like what do we use to diagnose our patients?
Yeah, I mean, we've talked about a lot of these. Chest x-ray, that's always the starting point, right? I mean, it's simple, it's quick, low radiation. So we can get a good idea if it looks normal or abnormal. A lot of times, if that is abnormal, we're going to have to step it up, right? We're going to need a more detailed study. And in other cases, even if it's normal, we need a more detailed study to make sure we're actually ruling out a problem. So that next step is going to be the CT scan, right? Where we're going to get the three-dimensional images. We're going to get thin slices, high definition. We're going to be able to see what's going on. Specifically, structurally. ILD is a great example of this, right? Patient comes in with shortness of breath, cough that's been going on for, weeks to months to maybe even years. A chest x-ray may not cut it, right? We need to go to the CT scan to get that answer.
Exactly. So you're going to step up from there. And then and I don't know if it's considered a step up or not yet, but stepping up from a chest CT, you might get either a PET CT or even an MRI of some sort, right?
Yeah, it depends on the question you're trying to answer, right? So occasionally a PET scan may be the appropriate test to see how active a specific area is, a nodule, or say someone with sarcoidosis to see how active the sarcoidosis is in their lungs, their lymph nodes, the heart, those sorts of things. And then you mentioned MRI, which amazingly is not a test done in the lungs in general. Historically, it's never been done because it can't see the lungs actually. There is a newer study that is actually even approved through the FDA where you inhale xenon and you can see the xenon with the MRI. So you can actually see the distribution of the gas in the lungs.
And when you guys think about PET CT, what we're talking about, if you look at cancer, right? Really any type of cancer, whether it's a lung cancer or any other type of cancer, those cancer cells, they're growing really fast. So they take up a lot of glucose. And what these PET scans are doing is you're giving people radioactive glucose so you can see it. And when those cells are taking up glucose and you get a PET scan, you can see the cells that are taking it up really fast. Now, typically speaking in the lung doesn't take up a whole lot of glucose. But if it's a cancer Or if it's an autoimmune condition like sarcoidosis, it's going to take up a lot of glucose. And you can see that light up on the PET scan, which is why sometimes we want to get the PET scan in those types of patients. And from an MRI standpoint, an MRI actually works how? How does an MRI actually work?
Well, so, an MRI is using big magnets and radio waves to see inside your body. It's looking at the protons. So that's why the lungs, you can't actually see them because it's mostly air. So historically, we don't do it for that. You may get a shoulder MRI or some other, knee, something, brain, obviously, but not the lungs until more recently.
And the reason that we can take advantage of it now is, like Chase said earlier, you're just inhaling a gas that you can see under certain imagery, right, on a Xenon MRI. And so that's what we're doing, is we want to see how the air travels from the environment through your lung, through those pipes. Is it getting through those pipes? Remember, asthmatics, they can't get air through those pipes as well, right? Or they might have a mucus plug, so air is not going to go through the pipe, right? Patient with COPD, they have lung damage. So not only is that pipe not able to get air there, but perhaps somewhere along the way, that lung is damaged as well. And you can see that on Xenon MRI too.
Exactly. You're seeing the functional consequence of whatever that disease is.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question: what should be in an asthma action plan for my child? This is a great question. When I think about an asthma action plan, first we have to remember what asthma is: allergic inflammation of the pipes carrying air to the lung. Turns out my daughter had an asthma attack on the soccer field just yesterday. So what was my action plan as her pulmonologist and really her dad? Here's what we do. We make certain that our patients have their rescue inhalers, which includes an inhaled corticosteroid and a short-acting beta agonist taken together when they start having wheezing, coughing, or shortness of breath. The next thing we make sure of is that we alert their patient's pulmonologist or their patient's allergist, whoever is managing their asthma, to make certain that they might have to step up their maintenance therapy for their asthma. That is the most important thing, and that's the buzz. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to see how much you can save. All right, Chase, this is going to be fun. So we're going to call this Chasing Doctor's Orders.
Oh, I like what you did there.
All right. So I want to know basically like your foundation for how you're managing your people and what you're telling them. So here's the first one. Give me one thing you wish every patient would do for the lungs starting today.
I would recommend exercise. Your lungs may not work perfectly, but at least you can teach your body how to utilize what it's getting better.
That's awesome. One habit people should quit immediately for better breathing.
That's simple. Stop smoking.
And I would even take that a step further. I would say if you can, recognize the environment in which you live. And if you're in an area that's heavily polluted, see if there's a way for you to move to a different space. If you can't, seek healthcare in some way, shape, or form, and just make sure you can see somebody that could help you if something were to happen.
Exactly. Don't put anything in your lungs that's not air.
Yeah. Listen, you guys, I know you think that vaping is healthy. It's not. Smoking anything or vaping anything is not a healthy thing. One activity you'd write a prescription for that has nothing to do with medicine.
Take your wife on a date.
I agree with that 100%. Take your wife out every week. If you notice that you and your wife are less touchy, take her out, take him out, whatever. Go take out your spouse and have some alone time. If you got kids, leave them at home or find a babysitter, but go spend time. I agree. Best way to keep lungs healthy as we age.
I think continuing to exercise. I still think that's one of the most important things we can do for our lungs. That and, you kind of touched on this previously, thinking about your environment, right? Thinking about the air quality in your environment, not just, if you're in a city, but thinking of your home environment. Do you have water damage, mold that's happened in your home, your occupational exposures that you have? Thinking about what you're exposing your lungs to long term, because it's usually 20, 30 years down the road where those problems start to show up.
Yeah, so your go-to advice for people living in areas of poor air quality would be pay attention to what the air quality is and try to stay inside if you can.
Exactly.
Or move if you can to an area that's not as heavily polluted.
Yeah, and you could put HEPA filters and things like that in your house to help, but yeah, you don't want to be going outside when the pollution's high.
The air purifiers, Like some people believe in them, some people don't. I'm a guy where I've opened up an air purifier like too many times and changed the filter to be like, whoa, there's a lot of stuff in there. So I use them in my house. Like I keep them in my house.
Yeah.
We just got our bedroom. We added on to our bedroom, and I kept an air purifier like right outside the room that they were building. They were like adding on a whole new room. And I just saw the amount of particles within the purifier. And I was just like, I am so glad this was here.
Yeah. It's definitely not hurting.
It's no, exactly. What's one thing you wish everyone knew about early diagnosis for lung disease?
Specifically talking about ILD, it impacts survival. The earlier you're diagnosed, the better the outcomes.
You know, one of the things I want to say to clinicians out there, urgent care, ER, internal medicine doctors, if there's any suggestion of inflammation on a chest CT, if there's any suggestion of a pulmonary nodule on chest CT, please make certain that you follow this up, either sending the patient to a pulmonologist or making sure that you understand what needs to be done, because this does affect outcomes overall. Like you can definitely treat a patient earlier and it's going to improve the outcomes over time. Even in diseases like asthma, we know that people who are treated earlier, they're more likely to be in clinical remission than individuals who are treated later, right? And asthma's kind of changed over the course of the last 10 to 15 years in terms of how we manage it, right? Because we've learned so much about it. In fact, when you look at asthma, we don't really have an imaging technique for it, right? When we're diagnosing it, what do we typically do?
Symptoms, really, right? So, we'll get spirometry, symptoms, what kind of triggers are leading to your symptoms. But we don't have any imaging that's really answering that question for us.
Do you think that MRI or Xenon MRI can help with that?
Absolutely. So it's been very well studied in clinical trials and research studies. Essentially, these ventilation abnormalities that we talked about, the VDP, the higher the VDP, typically the worse asthma controlled patients have, the more likely they are to utilize healthcare resources, have exacerbations, and bad outcomes.
So when you have these patients that have asthma, and about 20 to 25 million people in the United States do, the people who have the most severe asthma are the people that are in the ERs all the time. They're using a lot of healthcare. They're getting a lot of oral corticosteroids. They're getting, a lot of treatment in the ER and can't even make it to one of our offices because they're always in the emergency room. Xenon MRI can identify those people a lot earlier and can make certain that they get to the right people.
Yeah, for sure. I mean, I think it comes back to sometimes the spirometry is normal. Sometimes we don't listen as well as we should to our patients. And here we have an objective test that can give us this clear visual evidence of the disease that's going on.
And I think that's important, the visual evidence, right? Giving a teenager or giving a young adult who's in college a picture that they can keep on their phone in their favorite section that shows that their lung is abnormal probably allows them to use their inhaler like they're supposed to, easier, more, whatever, right? They're more compliant with their treatment, which I think is great.
Yeah,
Yes.
you take an image before giving inhaler, take an image after. Look, this is what's happening. This is how this medicine is helping you.
And with biologics, now understanding that certain cytokines lead to the production of mucus, if you inhibit those cytokines and you don't, and you get less mucus, you can actually compare the image before biologic and after biologic and see the improvement as well. And I think people like that. Here's a picture before, here's a picture after. It's so much better.
And quickly, you could see those changes in a few months, probably a few weeks.
Yeah, if we got the image soon enough. With COPD, what do we typically do from an imaging standpoint for that illness?
Yeah, so typically we're looking at CT scans again, and sometimes we don't even utilize that a whole lot. But, we could see if it's airway disease or if it's tissue destruction primarily. So that's the main mechanism. But there's increased interest in mucus plugging in COPD as well right now.
Yeah, definitely. Because again, some of the same cytokines that are involved in asthma, we call them type 2 inflammatory cytokines. Up to 20 to 40% of patients with COPD may have this involved, and it leads to a lot of mucus production as well. And so if you look at Xenon MRI in that subset of patients, there is definitely use there that's going to allow us to recognize disease early, allow us to recognize treatment response as well.
Yeah, I mean, there's a few different things. I mean, one, we can actually measure the terminal airway size. So when you're talking about people that are live in heavy pollution environments, we can actually start to see if the airways themselves are becoming abnormal at an earlier stage.
Oh, wow.
And then when you come back to the mucus plugging, we can combine this with CT to see the mucus plug and the functional downstream effect from it. And when you start treatment, does that functional defect improve, right? That's ultimately what we want. It's not the mucus plug. Yeah, we want to see it improve, but we want that functional abnormality to improve. That's the problem.
And for you guys listening, like if you have COPD, if you have asthma, what we're really talking about for you is, are you going to be able to play catch with your kid when they get older? Are you going to be able to walk up those stairs? Are you going to be able to go on a jog with your grandson or with your granddaughter? Are you going to be able to walk those things? Because for me, what I think about is I think about my grandfather who was on 4 liters of oxygen trying to walk up to the place where I graduated college. So these are what Xenon MRI can offer you is the ability to understand that function of your lung, the ability to understand if the medication that you're on is actually helping you. And I think that's important for patients.
Yeah, and I think, a lot of people struggle with stopping smoking or whatever their habit is that's damaging their lungs, and actually being able to see the damage that it's occurring maybe before other tests are showing it. That's important, right? That can hopefully motivate you to ditch that.
But also for diseases like cystic fibrosis, which is really, again, it's a genetic disorder. We know what it is. It affects younger patients. They develop this really dense mucus, right, that they can't get out of their lung as a result of a lack of function of an ion channel. So if this happens to these individuals and they have mucus plugs, you can see it on Xenon MRI, right?
Yeah, I think the interesting thing with, CF patients is they have phenomenal treatment now, right? I mean, that's one of the game changers in the world of pulmonary medicine is CF care, how that's evolved. Really an important thing right now is a lot of these other things that they've historically done, they may not want to do now that they have these highly effective therapies. And also studying new drugs. How do you prove a new drug's helpful in these patients that are already on a great therapy, right?
Mhm.
And that's where Xenon MRI can actually pick up those changes where, spirometry may not pick those up.
One of the things that we see a lot is patients with pulmonary nodules. On a CAT scan, it's going to look really, really white, almost like in a well concentrated area. It doesn't have to be a circle. And we're going to pick it up on CAT scan. Now, typically speaking, and Chase and I talked about this earlier, there's these, we call them the Fleischner guidelines, right? Or the Fleischner strategy of nodule management. Anything under 4 millimeters, generally speaking, you don't care about if it's that small. If it's in between 4 and 10 millimeters, it's really like, what's your environment? Are you a smoker? Were you a smoker? Right? Are you in an area of high air pollution? Whatever. We're going to watch that over the course of a couple years with CAT scans. If the nodule gets bigger quickly, we're going to want to cut it out. But when we cut out a nodule, we cut out some of that lung. And so we have to evaluate how much healthy lung we're cutting out, right?
Exactly.
And
Yeah.
and so in individuals that may have to have this surgery, this test can be very helpful too, right?
For sure. I mean, think about this. The more tissue you remove around a nodule, the better, right? You want to get as much of the potential cancer out as you can. But right now, the way we primarily assess that is going to be spirometry. We're going to look at your FEV1, we call it, how much air you can blow out in that first second, and your DLCO, how easy the gas transfers. But we're doing a procedure on a specific area of the lung. Doesn't it just make sense? We want to know how the lung is working around that area and what are you going to be left with? How does the lung that you're going to be left with function?
I'm glad that there's something like this that can provide us some value because so many times, I mean, I can't tell you how many times I've been surprised where a portion of lung is taken out and the patient is just awful. And I'm like, man, we did everything right. Like I said, everything's going to be cool, like whatever. And the patient just feels like complete crap and can't breathe and can't do anything. So I think that this imaging technique really would be beneficial if it was done more commonly in that population of patients.
Yeah, it just makes sense to understand what they're going to be left with and what you're taking out.
Now, when you look at interstitial lung disease, which is something you and I both love, right? Interstitial lung disease is, how would you describe it? What is it?
This is how I describe it to my patients. Interstitial lung disease is kind of an umbrella term, right? There's hundreds of diseases that fall under interstitial lung disease. But essentially, the core of it is you have inflammation and scarring that's happening in the lungs. So gas can't transfer as well, and you can't take as big a deep breath in. You can't hold as much air. And over time, that gets worse and worse and worse. So that's basically how I describe interstitial lung disease to my patients.
And I kind of have this chart in my head where I have ILD at the top, then I have idiopathic interstitial pneumonias, I have hypersensitivity pneumonitis, I have connective tissue disease related interstitial lung disease, I have sarcoidosis, and then I have other,
Yeah.
where I have
I had the same
lamb.
table in my head.
Yeah, yeah, right. We have it. Right. Yeah, exactly. You have that table in our head. And in these individuals, what you just said, like you're not able to take oxygen from the air and put it in your bloodstream as easily as you would like. That's
Yeah.
all it is.
Yeah.
But to recognize it early requires us to get certain imaging, like HRCT or CT scans, and to really be able to read that scan and have sensitive enough eyes to say, something's not right here,
Yes.
right? And so many times it can be missed,
It's missed.
right? Why do you think people miss it?
Well, I think there's a combination of things. I think one, there's a lack of chest radiologists, right? People who have expertise in reading those specific CT scans for those specific findings. A lot of patients are coming from rural areas, and the person reading the chest CT is the same person looking at the MRI of the brain or the MRI of the shoulder, the ultrasound of the liver, and they don't have that expertise. And also part of it's how they read it, right? They may say, oh, there's some scarring in the lungs. You say that kind of sounds like a chronic change that's not going to get worse over time. And so they don't specifically say, hey, this is concerning for interstitial lung disease. I recommend you see a lung doctor. And I think that that would make a big difference.
And I think, again, what you guys have to understand is all day long, you're inhaling different particles from the environment all day long, right? You're walking on the sidewalk and auto exhaust is right in front of your face and you inhale that. You work in an industrial factory that melts metal and you're inhaling that. You vape, which is basically heating metal and different solvents and generating different types of molecules because of how hot these chemicals may get. All these things you're inhaling. So your lung is constantly exposed to this environment, this concentrated environment that can activate the inflammatory response at any given moment. And if this inflammatory response happens, those inflammatory cells can actually recruit over cells that lay down scar. And when you have cells that lay down scar in combination with cells that are causing you inflammation, your gas exchange is just messed up. Sometimes you can't even see this on CAT scan because it's happening microscopically. Very, very tiny cells, and that injury is just starting to take place. But I'm guessing with MRI or Xenon MRI, can you see these things or these changes maybe a bit earlier than you would on CT scan?
Well, that's an interesting question. So, this gas exchange component of Xenon MRI is done on a research basis currently. And there's been some really interesting things that have been found. So, one is in patients that have interstitial lung disease. If you look at their CT scan, let's say you can visibly see the interstitial lung disease on the CT scan. There's a portion of the lung that may look normal. Say for IPF, the bottom parts of the lung have fibrosis and the top parts may look relatively normal. Well, when we do Xenon MRI, we can actually see that the membrane uptake is really high in those normal appearing regions. And there can also be impaired gas exchange. The RBCs, the red blood cells, are not picking up that xenon, which is really interesting. This suggests that the disease is happening in areas that look normal, like you mentioned, on CT scan. And what people have found actually is that the patients that have the most abnormality in that normal looking lung are the most likely to progress over a 1 year period of time. So it seems as though we may be measuring disease activity that's invisible.
But again, you have this condition and this organ that's constantly exposed to the environment. So he and I, when we're looking at this patient, we know that this lung is under stress because it's inhaling a breath, right? And you're inhaling all these different particles and molecules that are activating this response. But on Xenon MRI, you can start to see these changes a little bit easier, and patients can see these changes. And so expanding the role of that imagery probably is important.
I think it all comes down to once we see those changes on CT scan, the damage has occurred, right? I think as a specialty that we should be shifting from a reactive specialty to a proactive specialty, right? Something is happening in the body that led to that damage that we see on CT scan.
Yeah.
And that's where we want to catch it and intervene before it gets to that point.
Yeah, 100%. I mean, I've always said this, pulmonologists are bad marketers. We're terrible at it. Like, if anybody in this room right now were to hold their chest, everybody would be like, oh my gosh, are you having a heart attack, right? Because cardiologists are great at managing it. But, there's a whole other organ that sits in your chest right next to the heart, your lung, right? And so we have to be better. And the way that I always try to explain it is just like, dude, your lung has a heavy responsibility. It's got to sift through all the shit that you inhale, and it's got to be able to sift through all that, not respond to some of those things,
Yeah.
and deliver oxygen to your blood vessels, all simultaneously, making sure that your body gets what it needs to give you that energy, because oxygen is the final electron acceptor and electron transport chain, which generates ATP to give you energy to be able to be yourself. And I think people forget about that. And so to be able to really understand that and really understand the function of what the lung is doing in your particular case requires more than just one quick image. I know you like deep learning and AI.
I love it.
Tell me how that applies to all of this.
Well, I think it all comes back to kind of this subjectiveness versus objectiveness. So when you look at CT scan or MRI, Xenon MRI outputs, we want to quantify them. I think patients would be surprised whenever we look at a CT scan and we say, oh, you've got fibrosis, and then we look at another one. We're not measuring that change. We're subjectively looking at it and saying, I think that might be a little bit worse. But deep learning and quantitative CT and quantitative Xenon metrics actually put a number to it, right? We're actually measuring it using these different techniques to see change and put objective measurements over time.
Imaging isn't just about taking a picture. It's about understanding what that picture represents inside your body, right? And I think what all of this imagery does, the CTs, the MRIs, the ultrasound, it's applying what that image is giving us to be able to diagnose what's going on in the patient and make them better.
Exactly.
Right?
It's not we have one test or this test or that test. It's how do we use these tests to build a complete picture of what's going on and how best to treat the patient.
One of the things I always like to do, especially at the end of a show, is talk about a positive outcome, right? Positive pulse, we call it. There's a patient of mine when I first moved back to California from Kansas City. There's a patient of mine, 60-year-old female. She was in the hospital. She was having an interstitial lung disease exacerbation. When I moved back, I was like, I'm going to be an interstitial lung disease doctor, right? Because the Hamblin and his influence on me and the immunology that I've come to love. And this patient had ILD clearly on CT. You could see the ILD. She was exacerbating, got a scleroderma antibody test. It was positive. I was like, okay, this is scleroderma alone. So I put her on an appropriate product, which at the time was, I think, nintedanib is what I put her on. I put her on nintedanib. She'd been on nintedanib for a while. She actually was better. She was also on mycophenolate mofetil. She was actually feeling a little bit better. But what it did was it allowed me time to get the patient evaluated at UCLA for lung transplant, and she had a lung transplant, and today the patient is fine. So this stuff matters to you, and it matters to you because it allows us to understand what's working for you, because we want you to be better. We want you to be walking, we want you to be running, we want you happy and healthy, and we want you to be able to go to your son's basketball game, daughter's soccer game, whatever, and have a great life. Chase, where do we find you?
You can find me in Kansas City at KU Med. That's where you can find me in the Interstitial Lung Disease Clinic, hopefully not in the ICU.
And you have an Instagram now that you educate on from time to time. Don't think I don't see
From
it.
time to time, yeah.
Yeah? What's the Instagram?
Chase Hall MD.
There you go.
Yeah.
Thanks for watching, you guys. We're on Instagram at the Health Exchange Podcast. Get us wherever you get your podcasts. We're on Apple, Spotify, iHeart, YouTube. Visit us there. We see you every Thursday at 6 a.m. Pacific, 9 a.m. Eastern. We'll see you this Thursday and also next Thursday. Take care.